Well, good afternoon, everybody, and thank you for coming to the next installment of the At the Elbow webinar series. Today we have Dr. Patty, who will be joining us, and we'll talk a little bit about his past experience and why he's here to talk to us today and share his thoughts. Today we're here to talk about new data. Okay, there is lots of data available, obviously, for many different aspects of managing clinician experience and health systems in general and IT. But today we're going to talk about very specific data that is intentionally collecting data or clinician experience, lived experience, when they're using EHRs, whether it's Oracle, Epic, or Benetech. And we're collecting this data for very specific reasons to fill a gap that exists in how we make decisions about improving clinician experience. So with this additional data, and Dr. Patty is uniquely qualified for this because he's been doing performance improvement for about 30 years. Mm-hmm. And so with where precision decision-making was not necessarily possible in the past, expectations have changed. The expectation now is proactive management of clinician experience. The expectation is having a common set of facts shared between clinical and IT executives. The ability to make precision investments to improve clinician experience, and then to be able to measure the improvement of those investments. Those are the new expectations that exist. I asked Dr. Patty to come on because he's been doing performance management for about 30 years. He used to be the Chief Medical Information Officer at Rush Medical Center, and he's been accomplishing these feats of improving performance and clinician experience without full data sets. And now he's able to really appreciate, I think, the new paradigm we're in, where having access to this data is simple and easy. To give you an example, at Rush Medical Center, which is a large university medical center in Chicago, he was able to achieve the highest score from Class Arch Collaborative for a university medical center, move the organization into the 90th percentile, where they measure the clinicians' confidence in IT. If you could imagine that. The confidence in IT was 90%. Which is just fantastic. And as a byproduct of that, I believe it's accurate to say, Doctor, that the clinician turnover moved from 16% down to, or 12% down to 6%. Right. So fantastic decrease in clinician turnover. Yeah. So,
and that was over just like an 18-month time period when we did this extensive work. So it was an excellent project.
That's fantastic. And so, Doctor, let me ask a couple of questions. Let me just say one little housekeeping. Dr. Patty and I will go through the conversation. We'll leave time for Q&A at the end, time permitting. So we're going to focus on 4 questions that clinicians and IT leaders can answer today with exact precision that they couldn't answer previously. Before they made IT investments, which is pretty scary, right? Yeah. So they had a lot of data, but they didn't have data on clinician experience. And a lot of these investments are made to specifically improve clinician experience. And so most of the tools that are out there and most of the data that exist to measure the IT elements that may impact clinician experience, but not clinician experience itself. And that's where we're coming in, is we're bringing in data to be able to give organizations the ability to understand what clinicians are experiencing from the clinician's perspective. Not, are the IT elements all healthy and therefore we should be having a good clinician experience, but we're still getting complaints from these 20 locations, right? So, Doctor, maybe in terms of setting the stage, in our previous conversations, you were describing for me, both at Rush and other medical centers and engagements you've been involved in. What was it like in sort of the reactive mode? You know, you're doing the best you can. I think at Rush Medical Center, you had a number of assistant CMIOs and other informaticists that did rounding. Explain what it's like in the old paradigm, okay, before this data existed, in terms of attempting to get ahead of clinician experience issues and manage them.
Yeah, and so, early in my career, and oftentimes when I come into organizations, I see people playing kind of the whack-a-mole approach, is what I call it. It's you see or hear of a problem and you attack that problem. And people are constantly in that what's the latest problem mode. One of the things I learned early in my career when I was at HealthEast Care System in the Twin Cities, I had a really good lean sensei, Didier Rubino, and he really taught me to take a step back and answer the question of what's the root cause of the problems. And then to take a proactive, evidence-based, data-driven, programmatic approach to the problems. So you're getting a very holistic approach. And that's where I developed the house of EHR success, if you will, where, I have EHR speed and reliability at the foundation of the house. And we'll talk about why that's at the foundation in a bit. And then 3 pillars. The first pillar is around, training, education, and support. If you're not doing good onboarding training, if you're not doing good ongoing education, if you're not doing good field support, you're going to have a bad experience. The middle pillar, if you will, is around giving end users a voice. So it's governance, it's rounding, it's a good communication program, a two-way communication program. And then the third is around making sure that the EHR is configured for the workflows and for that individual adequately. And so it's really about that personalized end user experience. And all of those things, that foundation of speed and reliability, those 3 pillars, all need to be in place to have a really sound house, if you will, of EHR, end user satisfaction in EHR. And we had some good data. We had really good data that we were getting from the Class Arch Collaborative Survey. I love that survey because it's externally benchmarked. And so you can see how you're doing based against other like organizations. We had Epic Signal data where we could see how well are people using the EHR? How is that EHR, what's their experience with the use side of the EHR? What we didn't have was that foundational layer of speed and reliability. We had mostly anecdotes. We had, when we were rounding, we got reports from people saying, here's what I'm seeing, here's what's happening to me, very anecdotal. We had anecdotal stuff from the surveys which said, yep, we have issues with speed and reliability, but it wasn't specific. It didn't get you to a root cause. And so we didn't have data on the frequency of a problem. We heard there's a problem. We don't know how often it's happening. We didn't have any data on the scope. I hear it from these physicians, but how many end users are being impacted by this problem? We didn't have that scope, people. We didn't have location. Is it just happening in this clinic that we're hearing it from, or is it all clinics, or is it in the hospitals too, or is it when people are logging in remotely from home or wherever? And we didn't have root causes. What's the likely root cause? Okay, now we've identified, we see the frequency, we see the scope, we see the location. What's the root cause of these elements? And obviously now what's changed is that now we have the data we can get from Goliath on that speed and reliability data, the frequency, how often it's happening, scope, who's it happening to, how many people are impacted, location, where is it happening, and what's the likely root cause. We can add that to the come from an Epic background, the Epic signal data on how well people are using the EHR, and add that to the data from the ClassArch Collaborative Survey. And now we've got a complete picture of what's impacting end user satisfaction. We didn't have that complete picture before.
And so, Doctor, let me ask a question. You know, you educated us a little bit about this when we were trying to generate, you know, we said, you know, I think we have some data that might be helpful. And so we started talking about it, and you educated me on the fact that when you do physical rounding, right, when you're rounding with clinicians, you're talking to clinicians, you can understand if a clinician requires additional training or maybe help with how to navigate an application, or maybe there's a application workflow that needs to be adjusted, right?
Mm-hmm. Yep.
But when it came to speed and reliability, this sort of the foundational layer, that no level of description, even when you're with the individual at their elbow, you can't really provide any meaningful feedback or actionable feedback other than this is the location, this is the date and time, and it seems like things are slow.
Yeah.
Right. So that the difference between the sort of the training, the education, and the workflow, application workflow needs, you can get that through direct observability, but you really can't get any meaningful information other than there's a problem. And then that problem is anecdotal.
Right. Yeah. I mean, I can be seeing somebody, you know, whether it's out rounding, whether it's a ticket that comes in. And as we well know, physicians are notoriously bad at submitting tickets because, one, they don't have the time, and two, they've oftentimes have seen submitting a ticket as putting something into a black hole. They're not getting any response back. And then you can get, you know, going to department meetings and things like that and querying people. And so you get a sense of login times are slow, but don't know why. Screen refreshes are slow. If I'm changing a screen, I'm sitting there waiting for the data to load, but don't know why. I'm dropped off the network. I don't know, but I don't know why. And so then you have to go back and try and troubleshoot that with IT. And IT sometimes would say, everything looks fine from our end. I don't understand why they're having this problem. So we didn't have that ability to, one, see what's going on and see a root cause, but also to see the frequency, the scope, and the breadth, the locations where it's happening. And we have that data now. And so we can come back and talk with real data and have a really good conversation with our IT teams to say, here's the effect it's having on our end users. And now let's look at this data and we can see that, yep, it's a real problem. And it's not just affecting the person that reported it, it's impacting, you know, these other 500 physicians, you know? And so we now know the scope, and we can say it's happening at these locations and it's happening this often. And here's the likely root cause. We didn't have that before. So it's great data.
So let me ask this. So we're answering the first question, right? The first question that can be answered today is, what is the actual lived experience of the clinicians when they're using the EHR application, right? Yeah. So and this is a good example, thanks, Kiri, of this data where you can see at a glance, and this is without rounding. Now, this doesn't mean you don't do rounding, as you pointed out, Doctor. You can do rounding, but it can be precision rounding. So here we're able to see how many clinicians are having issues, how many clinicians are having issues during the logon process, how many issues are being experienced when they're using the application. And then further down, you see the actual clinician, the application, and whether it's happening in those categories Monday through Friday, right? Whether it's morning,
or
evening,
Monday through Monday.
right. You know, so, but this is the level of data that is available now. In the past, when you were trying to communicate with IT, because my sense is, Doctor, when we were talking, that communicating the actual lived experience outside of the clinical group, right, into IT and other areas that need to know about it so things could be actionable. It sounds like that has always been a challenge.
Yeah, and it's not that the IT teams didn't believe us. We just didn't have. We had a lot of anecdotes. We might have surveys, and the surveys cover 20-40% of the your end user population if you're lucky, right?
Mm-hmm.
And it doesn't give you specific data. It can say people are experiencing speed and reliability issues, or login issues, but it doesn't. That's it. You really don't know much more than that. You might have a sense of location because of the physicians that are reporting it are all from this location, but not necessarily. So it's incomplete. It's an incomplete data set. Same thing with rounding. Rounding is very anecdotal. It's happening to these physicians that I rounded on. And so, but what you don't know is, okay, what's the root cause? What am I fixing? And how many people is it impacting? Is it just this one person? Is it a whole group of people? Is it the entire organization? I don't know that from surveys or from rounding or from going to department meetings or from looking at tickets. I have a sense of it, but I don't have concrete data. And like I said, I like, a proactive, evidence-based, data-driven approach to solving problems. And I didn't have a complete data set before, and which now, as you've shown here, we do have a complete data, a much more complete data set than we had before.
And so that brings us to the second question that we can now answer, right? Which is specifically, let's say the answer to the first question, what's the lived experience of your clinicians? And let's say the lived experience is not good.
Right.
The second
and you have to drive home the point. Patient care is immediate, right? If I'm trying to take care of a patient and it's taking me 30, 40 seconds to log on, that's time I'm not spending with that patient, or that's time I'm not getting my orders in on this, this issue that I've identified that's, maybe urgent. Or if my screen refreshes are slow, I'm sitting there, that's more time I'm spending on the computer and less time I'm spending with the patient. And so these issues are very impactful in real time.
And if these issues are experienced at the point of care, I would imagine it is the most frustrating for the clinician when that's the case. If you're doing pajama time and the application is slow, that's one thing. But when you're face to face with at the point of care with your patient, I would imagine it's very, very frustrating.
It's hugely frustrating, and I lived that. I was a clinician for 25 years. I lived through that frustration of I'm being held back by the system, and it's before I can even get to the application. The application itself might be frustrating me, but if I'm having problems just getting there or getting the application to load or getting logged into the system, that's even more frustrating, right? Mm-hmm. And so, it just adds to the frustration. Like I said, that's why we have this speed and reliability at the foundation. If you don't have good speed and reliability, I don't care how good your training and education and support is. I don't care how good your governance and communication is. I don't care how well you've configured your EHR. If speed and reliability is an issue, you're going to have end user satisfaction problems.
And so back to question number 2, which could now be answered, right? Specifically, who's having the issues? How pervasive are they?
Right.
And how critical? And I think you and I have talked about this a number of times. I know that we've lived it when we're brought in for engagements, but oftentimes the IT organizations are doing a better job than you might think, right? Mm-hmm. So we're brought in when complaints are amplified, which they tend to be when there isn't enough factual data, because the only people you're hearing from are people that are having problems. We've also found in bringing data into the conversation that clinicians sometimes will amplify their complaints because they're so frustrated.
Right.
and they feel like they have to kind of prove it. We were in a situation where one clinician was timing on his iPhone how long it took him to log on from various locations, whether it's the clinic, the hospital, etc., or at home. And so they feel like they have to sometimes justify it. All of this sort of makes things much more emotional and more subjective.
Yeah.
So talk to us a little bit about that. I know I've been in situations where we get in there and we find out, hey, wait a second, this is, of the 10,000 folks that are logging on a daily basis, it's less than 100 folks that are or clinicians across a group of rural clinics that, so it's not indicative of a wide-based problem, but a very loud, amplified problem.
Yeah. Well, and that's the beauty of having a good data set, is I now know what are my biggest problems. I used to have to rely on where am I getting the most tickets and who's screaming the loudest, right? and that sometimes was good enough, but that doesn't get me to a root cause, and it doesn't get me true numbers of how many people are being impacted. Now I can see, well, this is a problem that 50 physicians are having, and yep, I need to solve that. But here's a problem that 5,000 end users are having. I need to solve that one, right? And so I can now focus. I'm better spending my IT dollars on solving problems that are having the biggest impact to the organization, right? And I'm seeing actual root causes. So I'm not, oftentimes we would find a problem and we didn't have all the data, so we were taking an educated guess, a pretty good guess. Often, most of the time we were right, sometimes we were wrong, but we were spending money based on an educated guess, not on really hard data, right? And if we got it wrong, we've spent some money and we still haven't solved the problem, and the problem's there for a longer period of time, right? Because we thought we solved it, and now we have to go back out and resurvey people, reround, see if we've solved that problem, and that takes some more time. And so if the problem wasn't solved, if our educated guess wasn't right, the problem's persisting and people are getting more frustrated. Now we've got data one, I don't have to wait for people to report it. I can see, oh, hey, these 150 end users are having a problem, let's solve it now, even before I go out and round. And so now so sometimes rounding is, hey, I saw that you were having this issue with long login times, and it looks like we've solved it. Now your login times are a lot shorter. Is that the case? And then we go, yeah, how did you know? And you can say, hey, our IT team is great. Give them a kudos for, and you can go back and tell the team, Dr. So-and-so is so happy now that you solved his issue. And so you're getting good feedback back to the team to say, hey, this proactive approach is being noticed by our end users, and it makes them feel good. And it makes your end users feel good because you're solving problems faster before they even report them. And so rounding becomes a validation sometimes, because you saw the issue, you saw the root cause, you solved it before anybody even complained sometimes. And now you're out there and saying, hey, I'm validating, I saw this problem and I think it's solved. Is that right? And then, well, yeah, sure, it is right. It is better. Thank you.
And can you talk to us a little bit about the scope and the time it took to arrive at that sort of data?
Yeah. And so
at one point, when I was showing you, not this report, but an earlier version, you had mentioned, God, that would take me 6 months to be able to pull anywhere close to that level of data.
Yeah, because rounding and surveys are slow ways of getting feedback, and even tickets are slow ways of getting feedback. It takes a long time to accumulate enough data from those three ways of collecting data to say, here's the scope and the severity of my issue. it can take quite a long time because the data is trickling in. You know, rounding takes time, surveys take time, tickets don't always get filed. So the data is trickling in over a longer period of time before you can get enough to say, here's my big issue. Now I have a complete data set that's almost immediate. And I can say, here's my big issue. I already know it. I can now work on solving it, not work on getting more data to figure out what it is, right?
And so that brings us to question number 3, right? Which is, again, a question that couldn't be answered with a great degree of precision before, but can today. That is, so we've identified that there are issues. We've identified who specifically is having those issues. So the question 3 now is the root cause of those issues, right? What specifically is causing those issues? And I think that's where the data from that you're seeing on the screen here can, and there are many cuts of this data, but this is where IT and the clinical side of the house can really get together and formulate solutions.
Yeah, I mean, because what Goliath does extremely well is look across the whole IT ecosystem and how well it's all working together. You know, you've got your data center, you've got your networks, you've got your endpoints, you've got all sorts of individual areas where you can collect data, but you're not looking at that at everything holistically. And that's the beauty of Goliath, is it looks at the entire ecosystem and typically gets to a root cause of here's what's causing this login issue, or here's what's causing this slowness that these physicians are seeing. And now we have something we can solve quickly because we have a better data set of what is that root cause. And I don't have that incomplete data that I was working with before, and the slow input of data that I was working with before. I have fast input and more precise, getting down most often to a root cause almost immediately, whereas before it took a lot of detective work.
Mm-hmm. And look, this is not to say when we talk about root cause that, you know, when we've worked with both clinical and IT departments, many times we're meeting together using now common sets of data. But that's not to say that they don't already know sometimes that, hey, we know that the networks have to be upgraded. These particular things have to be upgraded. What is missing is the link between those specific enhancements many times and the clinicians that they're impacting.
Right.
And without that, it's very difficult to establish priorities, right? And of course, to baseline exactly what clinician experience is. Remember, we're only providing one cut of data, but this data is a missing piece of data. And it should be noted that we're pulling a lot of this data from the EHR systems and correlating them with other data ourselves, right? So what makes this data probably different than other data sets out there is that it's purpose built to be providing this data for Oracle, for Epic, as well as for Meditech.
Yeah. And like I said at the top of the show, you know, it's not like I wasn't dealing with data before. I just had a less complete data set. I had really good data on end user satisfaction from the Class Arch Collaborative Survey, which again, like I say, I love. I'm not a member of Class. I just love using their survey. I had, coming from an Epic shop, I had really good signal data, which really showed how well people are using the application. So I had end user satisfaction data. I had application use data, but I didn't have speed and reliability data. That was mostly anecdotal. From the survey, I got some anecdotes. From rounding, I got some anecdotes. From tickets, I got some anecdotes. But I really didn't have that precise data of, you know, scope, location, duration, frequency, and root cause, which now I have that data set as well. And so I'm able to really solve more issues more quickly with a more complete data set. And I'm being proactive because I have this data even before it might be reported. I'm making data-driven decisions because I can see the scope of it, and I get more immediate response of, did I solve the problem? Because I can just rerun the Goliath report and say, is that issue now gone? I think I fixed it. Is it gone? Versus having to go back out and round, resurvey, or whatever, so that the feedback loop is much shorter with Goliath around speed and reliability issues than I ever had before.
Right. The gap that you're talking about, and whether it's signal data from Epic or System Pulse or Lights on Network from Oracle, there's plenty of data, and this is sort of the gap that we feel. There's plenty of data about how clinicians are using the application. Precision rounding, I think you pointed out this the other day, Doctor, precision rounding has been around for a while, but it's been precision rounding from the application use perspective, right? Like, why is this clinician spending so much pajama time putting notes in the application? And then looking at that a little deeper and saying, wait a second, that's an older module or something like that. We've got to get that upgraded, right? What we're doing is talking about, can they get to the application? Right?
Yeah, and how well does the application itself perform
once they're in?
Speed standpoint, once they're in.
Mm-hmm.
And I didn't have that before. That was all anecdotal before.
Right.
I can go out and do time and motion studies.
Mm-hmm.
Very time consuming. I can rely on tickets and feedback, but I really didn't have a good immediate way to get at this data until now.
Right. Now that we have this data, 3 questions answered. The question now is, let's say we've done some analysis, and I can tell you, Doctor, and I think we've engaged with you with one of our clients where we've literally run these reports in our 2 hours. We'll be able to start to get live data, and they usually let them run for a week or 2 weeks to get a good sample set. But we've literally stopped millions of dollars worth of projects or had them reprioritized because they were proven that the issues that they thought were issues were not issues, and they weren't issues at those particular locations or for those reasons. Right. So having the true root cause, and this is what's crazy about it, isn't it? That we're in a digital world. You ought to be able to know, and there is a digital footprint if you're willing to collect it. There's a digital footprint of every clinician who logs onto that application from the minute they initiate a connection through the use of the application. Right. It just has to be collected. It has to be analyzed, has to be correlated with other data, or it's just meaningless. Right? It's literally the digital data that we're getting could be as unhelpful as physical rounding if it's not correlated with other data elements to be able to create a more complete picture of what they're experiencing and why. Yeah. So let go ahead, Doctor.
Yeah, and so now, as a CIO, I can make better decisions on how to use my limited budget that I have, right? Because I can see the scope, the frequency, the severity of issues with much more accuracy than I had before. And so I can solve my biggest problems that are impacting the most people. And I have a very good understanding of what the root cause of that problem is. I'm spending my IT dollars more efficiently and I'm having more of an impact with my spend. And so it's kind of, when you're investing in a company, you look on their return on investment, right? Or return on equity. And now I have an ability to say, I'm getting a better return on the money I'm spending from an end user satisfaction standpoint than I did before, because I know I'm solving the biggest impact issues first.
Mm-hmm. So the final question here is around how do we measure improvements? And Kiri, I think we have one sort of graphic to show here that was from an actual organization running Epic, by the way. And certainly Epic was blamed, but Epic was not the issue. It was other issues within the organization. But doctor, talk to us a little bit about this. Talk to us about, so when you're at one of the, before this data existed, you're at an organization, you're having you've done the rounding, you've done the analysis, you lay down some investments. I think at Rush, they moved Epic to the cloud, which was sort of a frontier move, if you will, at that point, right? A lot of people weren't doing that. And it turned out to pay great dividends, my understanding is, right? So talk to us a little bit about that and how you do the before and after. You mentioned a little bit, but you would have to just sort of recreate or recycle the same efforts.
Right. Yeah. So like I said, the feedback loop is shorter, right? You make better decisions if you're the shorter your feedback loop is, right? If I'm sitting in the shower and I turn the knob from, it's too cold, and I turn the knob a little bit, and it takes a minute before I get the response of, okay, the water's warmer now, I'm going to be, overturning it. Now it's too hot. Now I turn it back. So your feedback loop is faster. If I turn the knob and within a couple of seconds, I now have, okay, now the water's warmer. I can rely on that the knob is at the right place, right? Mm-hmm. Same thing with your IT is I was making investments and making changes, but my feedback loop was slow. I had to go back out and round. I had to resurvey. I had to look and see if the tickets have improved. I didn't have immediate feedback of I've gone from 2,700 to 125 end users impacted, or my connection speeds have gone from 1204 down to 52. I didn't have that almost immediate feedback loop, right? And so I'm making better decisions faster. I know I've impacted the organization. I can move on rather than going out and trying to figure out, okay, did what I invested in, the knob that I turned, is it solving the problem I expected it to solve? Right. And that feedback loop is much faster now.
Mm-hmm. Yeah, this graphic that you're seeing here, this is a 30-day speed and reliability assessment where of the 10,000 clinicians, 2,700 that logged in were having problems. 30 days later, it was 125. So pretty dramatic decrease. And this is all within a 30-day period. And that improved going forward. This was just the first 30 days of the assessment. So, Dr. Patty, question for you. When it comes to now thinking about being a CMIO, or when you're going in and talking to folks about performance improvement, how have the expectations changed? And when you're talking to folks and saying, by the way, this sort of data exists today that didn't before, what's the typical reaction? We still get folks that are saying, I did not know this existed. And moreover, I didn't know that it was so easy and inexpensive to get.
Yeah. Well, and one thing I get first is, when I say, we've got really, you now have a better data set on end user experience and satisfaction. They say, well, we're already getting that with Signal. How is this different? And as we discussed earlier, Signal is great data, or whatever EHR you're on. I come from an Epic shop, and so that Signal data is how well are people using the application, right? but it tells me nothing about the speed and reliability of that application. And now I have that data set too. And so I've got two really good, almost immediate feedback loops of how well are people using the application and how well is the application being delivered to that person before they're actually using it.
Right.
And so I'm making, you know, like I really encourage people to take an evidence-based, data-driven, proactive approach to solving end user satisfaction. I now have a much more proactive set of data to make decisions on end user satisfaction. And I can make decisions quicker, and I can make better, more informed decisions. And so I'm having a faster, bigger impact on my end users from a satisfaction standpoint.
Yeah, in fact, we're together, we're engaged with a health system now, teaching them how to use this type of performance data before for the informaticists before they round. Talk a little bit about that, because one of the things that I thought was really interesting that you brought up was the fact that the informaticists aren't expected to solve performance issues, but when a clinician is when you're rounding and a clinician is having performance issues, that derails the rest of the conversation. In addition to that, by most clinicians, as you mentioned earlier, they don't report. And so by understanding who's having problems, especially the ones that aren't reporting, gives you the ability to sort of change the dynamic a little bit, to be able to say, I noticed you've been having long logon times. I just want to let you know we're on top of it, and I've shared that data with IT. It just sort of, that proactive nature makes people feel very, very supported, you know?
Right. You know, it's like they care enough to be monitoring that, and I didn't even have to report it, and they knew that was an issue for me, right? That just develops that trust from the end users when, you know, or, you know, not even, we notice you're having login issues, IT's working on it. The better conversation is, we noticed you were having login issues. It looks like it's gone away. Your login times have dropped significantly. Is that the case? You know, and now you've got a win coming into your precision rounding, and you can focus on what you've seen around how well they're using the application, which is what I really do best as an informaticist, right? And I can help them use the application better. Or if a workflow is broken, I can go back and reconfigure that and make it work for the users that are using that workflow, you know, and I can train them better on some of the new functionality, you know, that's coming out. I can spend my time working on that in-person computer interface and not have to deal with, well, I can't even get in, so what good are you? You know, it takes me 45 seconds to log on, so why do I care about all this other stuff when I can't even get logged on, you know? And so you're right, it derails the conversation from the start if you're having those the connection speed issues, the network latency, all of those things. If you now have solved those, I can now spend more time on the stuff that smooths things out even more. And so I'm doing more of my true informaticist work rather than, you know, spending time trying to solve and report IT issues.
Mm-hmm. And Doctor, to close off on this, and those of you that sent questions in, we'll get those to Dr. Patty and send them back out to you. So thank you for all the questions. We ran out of time today. But Dr. Patty, if you could sort of wave a magic wand and give every health system one thing they don't have today to improve clinician experience, what would it be?
I mean, it's better data to work from, right? Mm-hmm. And whether it's Goliath data on speed and reliability, whether it's getting end user satisfaction data from good surveys like Class, or whether it's getting that signal data and knowing how to use it and knowing how to apply it. It's getting the data you need to now drive improvement.
Mm-hmm.
And this is a new data set that most organizations still don't have, and they should, that completes that picture. It completes the picture of that house of end user satisfaction that we didn't have before. We had good data on all the pillars,
Mm-hmm.
but we didn't have good data on that foundational layer of speed and reliability.
Well, Doctor, thank you for being at this episode of At the Elbow, and we appreciate your participation and support.
Thanks. It's been fun working with you and your team, because I really believe this is impactful and can be very impactful to organizations.
Yeah, I mean, our relationship started when we met at that event in Utah for the first time, I believe, right? So
that it did.
Great meeting. Great talking to you again, Doctor.
Absolutely.
All right?
Yep.
Take care. And thanks everyone for joining.